So, how soon after surgery do we start our adjuvant treatments? Certainly, in a postmenopausal woman with an estrogen receptor positive tumor, which has been established from the time of the biopsy report, we can start the aromatase inhibitors quite soon after surgery. We should be a bit more cautious in starting tamoxifen before the patient has returned to their normal activities. And the reason for that is that, remember, tamoxifen is a selective estrogen receptor modulator. It has an anti-estrogenic effect on breast tumors, but on other organs, including the blood, it has an estrogenic effect. So the effect on the blood is to increase coagulability, and therefore it predisposes to deep vein thrombosis. I would be very cautious about starting tamoxifen before the patient is back up and about their normal, usual activities. As for radiotherapy and chemotherapy, these modalities should not be started until about a month after surgery. And the reason for that is that both modalities affect wound healing, and you want to have the wound in a fairly advanced state of healing before you start either therapy. However, both modalities should also be started before 3 months after surgery, because after that period they tend to be less effective than they can be. So let's start with radiotherapy. How do we decide which patients will benefit from radiotherapy? Well, common sense tells us that the patients who are most likely to benefit are the patients most at risk for a local recurrence. And therefore, after partial mastectomy, all patients should have radiotherapy. That is, after breast conserving surgery, all patients should have radiotherapy. After mastectomy, the indications for radiotherapy would be 3 or more axillary lymph nodes involved by metastatic disease, or the presence of the tumor of cancer within 0.5 centimeters of the posterior resection margin, that is the margin adjacent to the pectoralis major fascia. And who benefits from chemotherapy? How do we select the patients for chemotherapy? As for radiotherapy, the patients who are likely to benefit most from chemotherapy are those who are at greatest risk for distant metastases. There are a number of prognostic indicators which enable calculation of the patient's risk for developing metastases, or should I have said estimation of the patient's risk for developing distant metastases. These include the number of axillary metastases, the tumor size, tumor grade, age, estrogen receptor status. Remember that estrogen receptor status is not only an indicator that the tumor will respond to anti-estrogen treatment, it is also a prognostic indicator. Patients who have estrogen receptor positive tumors do better than patients who have estrogen receptor negative tumors. The best way to determine the likelihood or probability that a patient will benefit from chemotherapy is to plug all of these prognostic indicators into a statistical model known as adjuvantonline.com. The statistical model at this website will calculate the probability that the patient will benefit from your chosen chemotherapy regime. And it will also give you the relative benefits of chemotherapy versus hormonal manipulation. So, armed with this information, you can then discuss the merits and or the risk benefit scenario in a given patient, and between the oncologist and the patient, they are able to make an informed judgment as to whether the patient should have chemotherapy or not. Another method of arriving at the decision, the likelihood of benefit from chemotherapy, is to do a genetic assay on the tumor. What is done in these cases is to count the a certain standardized number of genetic mutations in the tumor and to give the patient a certain score. The score determines the risk of metastases and therefore the likely benefit from chemotherapy. The makers of this genetic assay, however, have indicated that it is no more accurate at predicting the likelihood of benefit from chemotherapy disease than is adjuvantonline.com, which, by the way, is free compared to the genetic assay, which is quite expensive. Currently, the most commonly used adjuvant chemotherapy regimen is an anthracycline-based regimen. But remember the major side effect of anthracyclines, in addition to the general side effects of chemotherapeutic agents, that anthracyclines may cause a cardiomyopathy. So the patient who has pre-existing heart disease is probably not a candidate for this regime, even though it is more expensive than more effective than the older CMF or cyclophosphamide methotrexate 5-FU regime. The other modality in our armamentarium is, of course, hormonal manipulation, and this one is quite easy. The only patients who will benefit from hormonal manipulation are those who are estrogen or progesterone receptor positive, and these patients will benefit from anti-estrogen treatment. If the patient is premenopausal, that is the patient with an estrogen receptor, progesterone receptor positive tumor. If the patient is premenopausal, we use tamoxifen for 5 years to treat those patients. For postmenopausal patients, we use an aromatase inhibitor. Why the difference? Aromatase inhibitors have been shown to be superior to tamoxifen in postmenopausal patients, and that is why it is used as first-line treatment. The aromatase inhibitors work by inhibiting estrogen production in the adrenals. In a postmenopausal woman whose ovaries have shut down, whose ovaries are not producing any estrogen, the aromatase inhibitors will therefore inhibit all estrogen production and are very, very effective in inhibiting the growth, the local recurrence, and the distant spread of breast cancer in postmenopausal women. However, aromatase inhibitors do not affect ovarian production of estrogen. So in a premenopausal woman who still has her very functional ovaries, what will happen if you give her an aromatase inhibitor is that it will have no net effect on estrogen levels, because in fact the ovaries will compensate for the reduction in estrogen production by the adrenals and increase their own production of estrogen. However, you may use aromatase inhibitors in premenopausal women after castration, and that is sometimes done when we have an advanced estrogen receptor positive breast cancer in a premenopausal woman. What we will do is to castrate them either by using radiotherapy on the ovaries or by surgically removing them and then exhibiting an aromatase inhibitor. What of Herceptin? Clearly, very easy again. Patients who have HER2 positive tumors will benefit from Herceptin. What is HER2? HER2 literally means human epidermal growth factor receptor, and it is a member of a group of receptor tyrosine kinases known as epidermal growth factor receptors. These receptors are made of tyrosine kinase. They are not receptors for tyrosine kinase. They are receptor tyrosine kinases, means that they are made of tyrosine kinase. And what they do is to send signals when they are activated, they send signals to the nucleus to stimulate mitosis. And therefore, if you can inhibit the epidermal growth factor receptors, but if you can block them, prevent activation of these receptors, you can control cancerous growth. And EGFRs have become major targets for cancer treatment in almost all organ systems. In breast, the major target is the HER2 receptor. And Herceptin is, of course, the blocking agent. It's simply a monoclonal antibody to HER2. So we have exhibited all our individualized combination of adjuvant therapies in this patient. How do we follow them up? First thing during follow-up is to counsel the patient that they really need to appreciate and understand the concept of living one day at a time. Breast cancer is not curable in the sense that GI cancers are curable. For example, if you have a gastric or colon carcinoma, and after a resection there is no recurrence of the disease within 5 years, those cancers are considered cured. Not so for breast cancer. Breast cancers can recur up to 40 years after the tumor was removed and treated, and therefore patients really do have to appreciate the concept that a recurrence may occur at any time. The usual follow-up regime is to perform a physical examination every 6 months or so for about 5 years, and then every year after that. At each examination, you check the breast if you had done a partial mastectomy, or the mastectomy site after a mastectomy. And of course, you examine the contralateral breast. Examine the regional lymph nodes, including the supraclavicular area. Examine the contralateral breast, as we said before. Auscultate and percuss the lungs for pleural effusion, and examine the abdomen for hepatomegaly. And of course, if the patient has any specific symptoms or signs, then you need to investigate those as well. Go back to doing an annual mammogram on the contralateral breast if the patient had a mastectomy, or on both breasts if the patient had breast conserving surgery. We used to do an annual chest x-ray. That is no longer considered a sensible protocol. And bone scans should not be performed unless the patient becomes symptomatic, because it does not alter your treatment regimen. In closing, I would just like to say a few words about breast cancer prevention, as I promised earlier on in this session. Breast cancer prevention is currently offered to women between 35 and 55 years old who have a calculated 5-year risk of developing breast cancer of 1.7% or greater. This risk is calculated using a risk assessment tool, the most popular one being the Gale score. And this tool is available at the website of the National Cancer Institutes in the US. Gale, Dr. Mitchell Gale, is a statistician who developed this statistical tool. So from a practical perspective, you have a 35 to 55-year-old woman who presents to you with a lump, on biopsy or excision, the lump turns out to be benign. You are obliged to calculate that patient's Gale score, or 5-year risk for development of breast cancer. And you do that by plugging in some known risk factors for development of breast cancer into this Gale model. Those risk factors include age at time of first menstrual period, age at first live birth of a child, number of first-degree relatives with breast cancer, number of previous benign breast biopsies, presence of atypical hyperplasia in any previous biopsy, and the patient's race. And what you get, the output that you get, is the patient's 5-year risk of developing cancer. And if that risk is 1.7% or greater, the patient is put on prophylactic raloxifene. Now, raloxifene is a congener of tamoxifen, same group of drugs, but it has a much nicer, less severe side effect profile than tamoxifen. Although it's not as effective as tamoxifen, this smooth side effect profile gives it an advantage for prophylaxis. You don't want a drug that is likely to be causing too many side effects for prophylaxis. So the patient is given raloxifene for about 5 years, and that reduces the incidence of breast cancer in that patient by half. So if the patient had a 2% 5-year risk of developing breast cancer, the risk is reduced to 1%. And the patient continues to benefit from risk reduction long beyond the 5-year period during which you give the raloxifene.